unlocking AI's true potential. And my objective for the session today is we can go beyond talking about generic statements, talk about specific insight from implementations, from experiences of implementers, and from a perspective that has actually driven innovation in the space. I'll take a few minutes to introduce our speakers. So first we have Dr. Aparna Hegde, who I think has many fans in this audience. And she is the founder of Arman and a urogynecologist, social entrepreneur, and she's really pioneered the work of Arman, which is now reaching over 500,000 healthcare workers, uh, focused on maternal and child health, and also is working on implementing AI-based solutions on the front lines. We also have Urvashi Vattal, who is the country lead for evidence and impact at Kushi Baby, also an organization that has pioneered some excellent work at the community level. And Urvashi has a gloried history at JPAL and is driving evidence generation in the space. We also have, Dr. Anurag Agarwal, who many of you may know, Dean of Biosciences and Health Research at Ashoka University. He's a physician scientist, a leader in genomics, and has many, many hats that he wears. But I think he's also driving a lot of the capacity building in the ecosystem that is then further has a ripple effect downstream. And then finally, we have Dr. Mithun Kumar Mitra, who's a professor in the Department of Physics at IIT Mumbai. And he's a theoretical physicist who's working on physics of living systems, statistical mechanics, and is also leading some large collaborations on TB treatment strategies and analytics. So please, can we start with a round of applause for our panelists? And uh, uh, our panel today, I hope that we are able to address three core objectives. We want to honestly examine what are some of the most promising AI interventions, predictive models, diagnostic tools, large language models at the last mile. We also want to talk very honestly about why they often fail to translate into measurable health outcomes for last mile communities. We want to identify what excellent practices are, right? We don't have strong evidence yet, but we have nuggets of insights from the community and we want to see what those are. And then finally, we really want to be forward looking and we want to honestly recognize the limitations and chart a way forward that prioritize the technology and real world impact over just algorithmic sophistication. So just a few key issues that we will be talking about today. The first of these is, and as it pertains to last mile populations, is data representation. It starts with the recognition that over half of our clinical AI models, they use training data from US or China. And we are deploying these tools in contexts that look nothing like the populations that they were trained on. We do have some evidence about how this impacts last mile populations, right? We know that they have 23% higher risk of false negative rate of pneumonia detection. We know that having, actually, if we've been trained here, we know that melanoma detection errors are much more prevalent in dark skinned patients because of data set imbalances. So there's some fundamental mismatch between the models and where we are applying them. And there are steps already that we are taking in India to address these issues, and we'd like to talk about what those are. There is also a second point of infrastructure gap. Um, because what it takes to deploy these tools is developing, training, and maintaining LLMs. It does require, or other computational models, it does require computational resources, which can really create barriers in low resource settings. And these computational resources are beyond servers and cloud computing. There is an element of human infrastructure, which cannot be addressed quickly, right? Which is a decade, 2 decades in the making. And achieving best outcomes does require a high level of collaboration between various experts and implementers that are in place. When we think about community health workers who are managing 2,500, 3,000 patients, they may work offline They may work in areas without reliable electricity. They may work on basic mobile phones. And most AI tools are less accessible to those without these technological resources, with limited digital literacy and in languages other than English. So even when we design offline capable tools, we face challenges that are essential for adoption. And then the third challenge is that of translation. And this is where the gap between AI capabilities and health outcomes becomes more stark. Predictive models can tell us that someone is high risk for hypertension or an adverse pregnancy outcome. But if there's no medication supply or no follow up infrastructure or no accessible clinic or no trained doctors, we still can't act on it. And what that in is a diagnostic gap without any therapeutic power, right? So anyway, I know we've spent a day and a half singing sort of the praises of AI, and so I'm not here to dampen our enthusiasm, but really I just want to ground this conversation in reality, so we can design solutions that work with our current infrastructure. And it's only when we acknowledge these constraints honestly, we can allocate resources effectively and create AI tools that can actually reach the last mile. So, with that, I can get us started. And maybe since Aparna, you're sitting right here, I'll first ask you to describe in the context of Arman, how AI is being used to leverage to support community health workers, their learning, and as well as identification of high risk pregnancies.
Yes. Hello. Can you hear me now? Yeah. So thank you so much for having me here. So Arman works both with women and children directly. Because our programs which provide information using ML solutions to them, and then we work with health workers at every level of the health system, the ASHA, the ANM, the medical officer specialist, so that they can pick up risk factors in time and manage in time and refer aptly. So I'm going to focus only on the AI bit of it, right, in this whole context. So we have a program called Integrated High Risk Pregnancy Management and Tracking. So what we found was that if you look at high risk pregnancies in urban context, when a woman has a high risk factor, she would go to an obstetrician, would manage her end to end. But in rural context, you have a three-tier system of referral pathway, which is important because only then you can have proper triaging. You have an ANM, auxiliary nurse midwife, the medical officer and specialist. But I was a part of the Antenatal Care Guidelines Committee of Government of India in 2019, and I got to notice that unfortunately each cadre does not know their part of the road. They don't know what treatment to give at that level, when to refer, what counseling to give, what to do when the woman comes back to the village. It is for each of these three cadres. So it's very important to create technical guidelines which are very simple for each cadre in addition to operational guidelines. And then we were given permission to create these guidelines for the Government of India. So for 35 high-risk conditions, potentially any high-risk factor a woman can face, we created algorithmic color-coded large detailed protocols. Very simple, right, for each cadre, right? And then there's a vetting process that happened with the national government and a lot of multilateral agencies and doctors from all over the country. And then COVID struck. In the meantime, several states accepted the program, right? We've gone to 7 states now and 14 in next year. So what do we do? And within this is the AI, for community health workers. And I'm giving you this context because this is why the program is successful, because within the context of this program. So what we do is when we go to any state, so Telangana is an example where we first went, we prioritize the conditions responsible for mortality. In Telangana's 22 conditions with the doctors of the state. We modified the protocol to suit the state because every state is different from the other with the doctors of the state at every level. Then it became policy. And then we're doing training. So literally 14,000 ANMs in the 7 states that we are have got trained through classroom training to the master trainers of the state on all of these protocols and in module format and in section-wise phases. And obviously in every state we have prioritized different numbers of conditions and different conditions responsible for mortality. After classroom training, we have a learning management system. So every protocol has been converted into live action videos, simulations, interactive quizzes, notification. It's on their phone or their tablet, the learning management system. And it's app agnostic. We go with what is available in the state. Then this is where the AI comes in. Now, so they are training the classroom, they are getting this on their phone, but then when they go to the field and they have any query, it's impossible to cover every part of the issue, right? Then they can ask any query to our A&M chatbot. Right, and we're very lucky to have Jigar here, who's collaborated with us from Arman. So it's an excellent A&M based support system, LLM based support system for the A&Ms. Any query they can ask, it answers, right? And it answers within 10 seconds latency, because it was 30 seconds earlier, now it's 10 seconds. They can send questions in the format of a voice note or in a text format. It gets spelling mistakes, grammar errors, right? It's multimodal, and it answers back. And it's because it draws only from the protocols we created. It's exhaustive. Nothing is left to chance. And then, so that's why the answers that come are pretty apt for the situation that the A&Ms are in. And we're very happy to say there's reached around 6,000 A&Ms, the whole of Telangana, 5 districts of Uttar Pradesh, and 1 district of Maharashtra as we speak. And we're going to scale it up to around 12,000 by March. And then there's plans are for large scale up for this chatbot. And then we'll discuss more about how it works. But then, the arts, I'll give an example of a real life question that came in from the field, right? इस प्रेग्नेंट वुमन का हेमोग्लोबिन 6.8 है, लेकिन उनको एलर्जी है iron tablet से, क्या करना है? Obviously, you're not going to include that in the protocol. So there is specific real world questions that are coming from the field, right? And the question now coming in on other aspects, not including the HRP. So their plan is to now expand, include even other conditions that the ANM treats, and then take it to childhood, right? And then we track, right? So the whole idea is that you trained, you handheld, you answered questions, and then we track the outcomes. The way we do it is protocols are getting layered in Telangana on the RCH database of the Telangana government itself. Every state has an RCH database, reproductive and childhood database, on which a few more questions for each high risk factor is getting layered, so that we can then track what is actually happening to the women. And then we can go and train again. Now that is where the chatbot hopefully in the future will do. It will just answer questions. We can send bite-sized lessons. We can send data on where the ANM has gone wrong to the ANM based upon her performance, or basically the performance of the area that she's serving, right? So there are a lot of these possibilities to the chatbot, not just giving answers to the question that she asks. Right, so this is where we are. We've reached 7. Obviously, the program is in 7 states, and hopefully, this chatbot now will go through the country. Yeah, thank you.
Great. Thank you, Aparna. And thank you for explaining that in quite a lot of detail. So there is a learning management system and then support. And what do you do when the chatbot does not answer questions?
Very important question. We also have a human in the loop, right? So obviously there's a question that's going to come in that's going to be difficult for the chatbot to answer, or the enemy not satisfied with the answer, right? So there's almost 98% satisfaction with the chatbot answers. 97%, it's been verified as medically accurate, right? But then there is any issue, there's a human in the loop who's always monitoring and answering the question that the chatbot can't answer. That the human in the loop is really, really important. It's tech plus touch. Yeah.
Great. So I think that's a great takeaway, tech plus touch. Okay, let's move on to Urvashi. Urvashi, Kushi Baby is testing a number of AI-based tools at the community level, including for detection of anemia, as well as community level support to ASHA and other frontline ASHA Saheli specifically. Can you talk a little bit more about these interventions and the types of resources that have been needed to deploy them?
Sure. Thanks. And thank you so much, Michelle, for having me on this panel along with everyone else. So I think just to give you all a context about Kushi Baby itself, we are a not-for-profit that works to strengthen public health systems through the use of data, not just collecting data, but also trying to translate data into insights and action. And I think like many people, I think who are interested in AI or sort of in this room, we've also been sort of, looking at this question of how do you leverage AI to strengthen public health services and delivery at the last mile. So I can talk about sort of 2 projects which are at various stages of sort of development and rollout. The more advanced of them is, I think, very similar to what Aparna described, but for a different sort of cadre of workers, the ASHA Saheli. This is also an LLM chatbot that's WhatsApp based. So the ASHA worker can communicate with the chatbot on WhatsApp, application that they already use. and ask questions about their sort of regular routine activities, any questions that they have about counseling that they need to provide to the households they go to. And for those of you who may not be familiar with the sort of larger public health context, ASHA workers are sort of the last point of care for a majority of the rural population in the country. And so they're sort of talking to households about delivery, about vaccinations for children, about nutrition, and they're interacting with various kinds of ailments on the ground. And what we've been doing is sort of leveraging our work in Rajasthan over the last 10 years, where we've worked for many hours with these ASHA workers to then identify certain pain points. And one thing that sort of came out from the work that we've done is that, they have intermittent refresher trainings, and it takes a long time to sort of get a response from an ANM or, other officials to queries that they have. Sometimes maybe only the monthly meeting that they go to. And so the chatbot is kind of a tool that they can use in the interim when they have some immediate questions, when they need to counsel parents or households immediately about any ask that they have. And so we initially did, and we've sort of, I should mention that we've rolled this out in collaboration with Microsoft Research. They're the technology partner behind this. And we've been rolling it out, starting with 20 Ashas in Udaipur district, a region we worked for many years, expanding to about 500 and now 11,000 Ashas across Rajasthan as well as Maharashtra. And I'll just sort of share like one example of the sort of response we got in the initial 20 sort of pilots that we did with ASHA workers, which was that oftentimes when they had a question from the household that they couldn't answer, they would have to wait for the ANM to respond, or they wouldn't be able to answer immediately. And therefore, having this chatbot is sort of like a confidence booster for them when they're out there in the field as well. In terms, I think your question was sort of, what's enabled sort of this to, scale at least up to 11,000 and hopefully more in the future. One is, of course, having Microsoft as the technology partner. Because they are the ones who sort of designed the tool itself. The second is, I think, all of our experience in terms of health systems, ASHA's constraints, their environment that we have developed working over the years. And then this is a project that's also been supported by Microsoft CSR. So I think having that initial sort of CSR or philanthropic capital to do these kinds of investments and develop new solutions, working with organizations like ours, I think is the sort of other element of this.
Could I ask Ravishi, what types of questions or what types of queries do you see Asha's?
Yeah, so I mean, it could be about, I need to counsel the household about family planning. What are the different sort of options I can recommend to them? Or a child is a certain weight. Is the child like sort of severely malnourished or not, or is it moderate? Those are the kinds of questions that they might be asking to the chatbot.
Okay, okay, thank you. Okay, let's move on to Mithun. Um, uh, of course, you're working on applying a variety of novel analytic techniques to improve TB testing and to assess effectiveness and impact of post-TB screening. Can you describe this work and also talk about, from a data standpoint, what are the opportunities and gaps you see in doing this type of work?
Thanks, Misha. Firstly, I think I come from a little bit of a different background
Yeah.
than the rest of the panelists.
And that's the beauty of the panel, really. Like, we want to talk about the data for the last mile too.
Good.
So,
So in general, what we try to do is to sort of make sense of complex healthcare data, right? So that's the broad overarching goal. And make sense of them through models, both AI models and otherwise. So it's both machine learning and old school modeling. So I'll use both of them.
and maybe
Can you hear me now? Okay, great. Right. So what I was saying is that, the main sort of work that we do is to try and make sense of complex healthcare data, and make sense of them through building models, whether machine learning models or more other traditional models, statistical models or other classes of models that take into account this data that we have, but also sort of considers the different levels of heterogeneity that we have. And in India, any sort of modeling that we do has to be sort of responsive to these heterogeneities, whether these are, geographical heterogeneities, whether they are socioeconomic heterogeneities, or whether they are cultural ones. And ultimately, the aim through this sort of modeling exercises is to synthesize this data and produce actionable policy insights, right? And we work with programmatic data from the government, but we also sort of try to, build in local data, so local surveys, local studies, and so on, wherever possible, so that our models have inputs both from the large scale as well as the local scales. In context of TB, Smisha, since you asked, so there's this work that we've been doing with collaborators in Hopkins, in fact, and where we're trying to look at post-treatment outcomes of TB. And in India, tuberculosis is one of the major infectious diseases. India contributes a huge proportion of the global burden of TB. We've made, of course, excellent strides, I would say, over the last decade to bring down, TB incidence, TB mortality, but there is still a long way to go before we meet the goals where we want to be as a country. And TB is, in that sense, it's a social disease. There's a lot of stigma associated with tuberculosis. People don't seek care. People try to hide their symptoms, and there's a lot of efforts that's going on. State governments, the national government, in order to go out there and find people. Convince them to come forward and to seek care. In this context, if you look at what are the major drivers of tuberculosis, one main group is people who have had TB in the past. So people who have recurrent TB infections. In fact, the National Prevalence Survey of India sort of estimated about a quarter of all TB cases come from these people. Now, that's of course a concern, but that's also an opportunity. That's also an opportunity because these are people who are already enrolled into your system, right? They've come for care before, and therefore, if you can optimize follow-up for these people, if you can go after the complete treatment, you go back to them after 3 months, after 6 months, after 12 months, and ask that, have you again had TB symptoms? You can potentially catch a lot of recurrent tuberculosis in the community. And this is important not only for the patients themselves, but it's also important because then you avert transmission in the community. If you do early detection, it's not just that person who benefits, it's the community who benefits. And these are sort of things that we are looking at from a modeling aspect. And also sort of, in different geographies, different factors come up. Maybe in some geographies, you have large number of migrant workers who are then lost to follow up. They don't come back and they don't follow up with the healthcare system. In other geographies, there might be adherence, concerns. So we can tailor our sort of solutions to the geographies, to particular geographies, so that whoever is responsible for the last mile care, in this case, let's say the district TB officer, can go and put some of these recommendations into action. More broadly, if I may, so I'm also part of a consortium called the National Disease Modeling Consortium. It was set up by with the blessings of the Ministry of Health and Family Welfare, and it brings together an expertise from the ministry, so programmatic expertise, expertise from ICMR, expertise from epidemiologists, public health experts, in order to sort of develop models that are tailored to the Indian context. We don't just take global models and just feed in our data. We try to sort of tailor these models that take into account this vast heterogeneity that we have in India as a whole. And we work in different disease domains. So we work in infectious diseases. We now work in non-communicable diseases. Maybe I'll use one example from a different disease. So lymphatic filariasis. I don't know how many of you in the room are aware. It's a very common vector-borne disease, which means that you get it when a mosquito bites you, common mosquito, Culex, and that transmits the parasite. It's a concern in that you can have the infection, and the infection can stay dormant in your body for a long time, and 1 year, 5 years, 10 years. So you can harbor that infection, you can spread that infection in the community. It's only a small proportion of people who develop acute disease, acute lymphedema in this case, which we call as hathi pav, get swelling of the lymphatic glands and so on. So again, this is a major concern in India. This belongs to a category of what we call as neglected tropical diseases, in that there's not a lot of funding globally, perhaps, to address these. So what we are trying to do is and again, similar to TB, we've made a lot of progress over the last 10 years to sort of in reducing the number of endemic districts. Endemic districts are in Bihar, UP, Orissa, parts of Maharashtra. But still, there's a lot to be done. And what, again, we're trying to understand is what are the socioeconomic, what are the cultural reasons behind this heterogeneity. So you might have one block which has achieved elimination, but just the neighboring block, even after 5 rounds of drug administration. So this involves something called mass drug administration, where we give medicines to all of the people in that block, right? Even after 5 rounds, 6 rounds, LF is still endemic. And what are the possible reasons behind this? So like you talked about data gaps, and in this context, one of the data gaps that we have is we don't have a lot of good entomological data in India. So especially in the context of vector-borne diseases, it's not just LF, malaria, dengue, LF, encephalitis, all of these. We have data for the human component. We know who gets the disease, but we don't have data about the vectors. How many mosquitoes are there? Where are they breeding? And this data is very important if I want to build a complete picture. I just can't, recommend policies or interventions without understanding the complete picture of the vectors. Similarly, there are sociocultural reasons. So, for example, when you give these drugs, oftentimes people don't take them. And there are groups of people who don't take them systematically, right? Year after year after year. So we call them these people who are never treated in the parlance. And why don't they take them? They may not take them because they may not have perhaps faith in the public health system. Maybe there is a lack of communication as to what these medicines do. What is the reason for these 3 tablets or so on that you give them? Maybe there are religious reasons. And again, this is where we have to leverage the last mile healthcare workers, because they are the people that are reaching the communities. They are the people that can inform the modeling as to why this is taking place, but also then take the solution back to the community, so that these sociocultural reasons do not stop us from achieving elimination. So
Thank you. And I appreciate that you brought the example of lymphatic filariasis, because it is actually I think people may commonly know it as elephantiasis, right?
correct.
So, because it is a last mile condition that is neglected, and
Right.
and the fact that you're able to have data about it, is that
So we do have programmatic data on filariasis. Yeah.
Great. Okay, so I will move on finally, Anurag, to you. Of course, you oversee a vast number of interdisciplinary projects and implement a number of interdisciplinary projects. I think what I would love to hear from you is, where do you see the greatest opportunities for now? And where do you see the shift for the future, right? Like, what is now, what is future?
I guess to answer that question, one way to look at it is what is new. Because what is old, the opportunities are mostly solved. And we could see that from the discussion occurring earlier, that chatbots, their capacity has risen with Gen AI and LLM. With RAGs, our ability, as long as we can find grounding for the truth, our ability to reduce hallucinations has become much, much better. What is missing typically is what to ground them on in terms of local data, local protocols. And we went to the other extreme of life for one use case, the end of life care, palliative care. As India ages, the demand for palliative care is almost guaranteed to go up. It is usually at that point not a diagnostic problem, it is an implementation problem of a plan that typically has already been built by the doctor. But almost no one ever understands the plan given to them by the doctor. If you were to go out into this relatively low health literacy system that we have, problem is not in creating the plan, problem is in getting people to manage the plan. And they keep coming back to the health system again and again for something that could have been dealt with at home. So that's an example where by using more modern Gen AI, multi-agentic workflows, quickly cross-checking all the time, very importantly, building the answer I do not know, or I will not answer this, you need to go back to the doctor for something critical. And also building knowledge repositories by working with partners like Pallium India. We have seen success. But then came the next big problem that I think was good instruction mechanism for us. We tend to apps. When you think only about an ASHA, you would think of an app. But what you really need is a voice based interaction that is even possible on a non smartphone. And again, we found with Bhashini, with Gemini, different layers of architectures, it is quite easy to put the AI behind a phone call. A person can actually call a number, and it's already implemented now. We haven't put out to the public, still in test mode. You can start speaking in the language you speak in. It'll be auto recognized on the other side, and answers will come back. And you can even have redundancies where you can move from a platform that has multi Indic language support to currently only Hindi, English, Marathi, which worked out fine for some parts. But this is, I think, an area that I see scaling quite well. We are trying to break the digital divide by recognizing that AI doesn't have to exist on the smartphones of the people that use it, but actually on the back end where they connect by voice. The second big problem that I think I'm going to mention is the biggest problem down the line is going to be procurement. How will you compare the various solutions that people will come up with? And unless the government has a mechanism, or forget government, even a hospital has a mechanism to compare and benchmark, everything will come to a paralysis because you simply don't know which solution works. It may even be that no single solution works for all. So there are two programs that we are looking at. One is with Microsoft Research, Gates Foundation, which is voice digital data for benchmarking of voice solutions. That's a separate category. But more important, if you think of India, we'll see more and more open source models tuned on local data being deployed. And while classical thinking for evidence is RCTs, I fundamentally think it's flawed because RCTs are sometimes for quantitative measures. Many of these tools that may have already been tested already come with a quantitative measure. What you want is a massively online A/B testing by people who are going to use it for the type of people that they are seeing in their practice. And they should be able to deploy multiple solutions together, preferably open source, so that any answers that you get of where the model is going wrong can be used to retune, retrain the system. This will be called Praman, and it's a offshoot of a system called Move, massively online validation evaluation by Annie Hartley. So this is something that we plan to bring. This will solve the other problem of building an evidence database for how useful different models are and building a community of users and building incentive structures for them. This, I think, might be more useful for what you give to an ASHA than a centralized program, because we have now seen that even for tuberculosis, right? In the beginning, chest X-ray for tuberculosis did well in Africa, came to India, failed. Dirty lungs of India was probably the cause. Got Indian data, it worked. Mega cities, now has gone to Northeast India and is again failing in some ways. So India itself is so heterogeneous that any one central program for the around the country is not going to work well. What you need are platforms to locally evaluate your problems.
Great, thank you. And since I hear this a constant theme of heterogeneity, so if you hold on to your mic, I think both you and Mithun have talked about the issue of heterogeneity, which is that there is of course a variety of data, and we do have a variety of subgroups, cultural context, languages. What can we do? Historically, maybe the first point is that what we've seen is that the communities that are the largest minorities have the lowest level of digitized data and lowest level of data that is actually portable, that is making it to research entities and universities. And so there is almost a one-to-one correlation between being a minority and having data. In some sense, it has to be a very active process of figuring out how do we get these data into digital formats, into formats that can be aggregated. And so I know there is work underway on it. And so if you could speak to that, and I'll pass the same
Certainly. I
question to
mean,
you, Mithun.
the biggest limitation in gathering digital data is because you're adding to the burden of overburdened practitioners. So, high quality voice to digital data, such that interactions are captured with consent, of course, and constitute the data repository, is absolutely critical. So, I think the Koida Foundation is investing heavily into creating a better ecosystem for voice to digital data. But I'll say one thing: if we wait for models to be built until we have all the data, we will never build the models. because it's simply not going to occur. What we need instead is a way to test these models continually, look at where they are going wrong, and use that with the basic corpus of medical knowledge in general to retune and retrain them. And we may end up with different ones in different places, but that's the only way I see it going forward, because capturing data becomes tricky because of privacy and a variety of other issues. The ones who are least represented might also be the most susceptible to abuse, and we'll never sort that out. But I personally believe in data solidarity, in which you use legislation to prevent abuse as opposed to restricting the accumulation of data.
Thank you. I think voice to data is a technology solution, right? Maybe I'm pushing you a bit more because there are lots of non-technology solutions, right? About community empowerment, mobilization, education, capacity building.
And the data solidarity bit was about that. But data solidarity as a principle is somewhat conflicted. Also, because at the time DPDP acts are coming, a variety of other things are occurring, the burden of collecting data might rise, which is why I loosely hinted at the problem by saying legislative solutions to misuse of data, as opposed to making data gathering harmful and education of the public in terms of how and well to share their data is required. But the data ecosystem is absolutely required. And going down and empowering communities in terms of understanding it is absolutely required. How to best operationalize, and there are a lot of loopholes, not loopholes, intentionally left provisions in the DPDP Act that allow researchers and the health data exchange, which is written in the Act, but nobody has built one yet, is the other project that we are looking to do right now with ICMR. Try to build the first real health data exchange where you leave data where it is, completely federated architectures, but allow it to be used. But until it is built, I don't want to go there. But we do need to build it.
Great. And Mithun, same question to you.
So yeah, I completely agree with Anurag. But just adding on to that, so for example, one of the ways or one of the reasons we collect data in India is mostly perhaps record keeping. You
Yeah.
keep track. You don't really collect it to be used in research, and there is a whole vast amount of data that is just lying there in some sense, whether in paper form or even in digital form, that is not being used to answer some of these questions. Who are the communities that are being missed? Who are the people that are being missed? So I think there's a lot of scope there. So we have to incentivize, data not just as performance metrics. So if you report a death, it's not bad. It's an opportunity to go ahead and correct that. And I think that comes again in these underserved areas. People are afraid, oh, if I report a high tuberculosis death rate in a tribal area, I have to then answer to the program. But that's not the way that we should be looking at it. So I think ensuring or changing our mindset in some sense, the data is not something to be afraid of, but it's an opportunity that we can build on, can hopefully answer some of that. And I also agree with Anurag that, models can actually help point out where there are data mismatches. So, if for example, an epidemiologist or a local health worker is saying that in this area we should have these many whatever TB deaths or these many other infections, but the models or whatever notifications are captured in the government databases are not in tune with that, then that can go act as an incentive to sort of go ahead into these communities and try to collect the data that is missing.
Great, thank you. And I appreciate the summary of data, not just merely as performance metrics to drive last mile. I know that you have thoughts about this idea of data representation, but maybe you can reflect on that. But I'd like to add a question for you. And this is around often solutions fail because even if they're good solutions, because they are implemented in a context that is just not the right context. And early on in digital health, we saw a lot of this. Let's send messages to pregnant women about their behaviors. And we haven't seen what mobile phone ownership is in pregnant women. It's under 20%, migratory population, husbands are phone owners. So, of course, it's an intervention that's unlikely to serve last mile, and many examples of of similar problems being scaled up actually before anybody looked at impact. So my question to you is, of course, around the enthusiasm about AI. It is immense. But what do you think is the critical underlying ecosystem that is needed to implement these solutions, including data, which might be one of the.
Yeah, I'm going to keep it very short because of lack of time, right? So I'm going to answer from the context of our own program. Our A&M chatbot is working well, and also it's via WhatsApp. Yeah, same thing. Yeah, it's working well because within the context of a program that's working, right? If you look at the protocols and the question answer that it draws from, the chatbot doesn't draw from the World Wide Web. It draws the answers only from the universe of the protocol that you created, which has been vetted so thoroughly at every level. It's so algorithmic, absolutely last detail, that nothing is left to chance because we have that basis really done well. Secondly, we also, when we go to a particular state, we also then do kind of a mapping of the clinics, whether you can actually implement the protocol we're talking about, right? It's not enough to have, oh, give Maxulf if you have got eclampsia, but is Maxulf available there, right? Or is it possible? And every state differs from the other. So when we go to a particular state, we really, really, work with the state to understand what is possible and the protocol modified based upon that. And then the chatbot draws from those protocols for that state. And only then can it answer, right? So honestly, nothing can work in isolation. You cannot create an Asha chatbot or an ANM chatbot unless that groundwork has been done, right? So that is the thing I want to talk about. And it's something as simple as language and dialect, right? In Mumbai, we have a chatbot for women directly, right? And we use the word anemia everywhere, right? You think it's well known, but they don't understand anemia. They know khoon ki kami, right? Same thing with diabetes, right? If you use translation, regular Hindi translation of the word diabetes, they don't understand that. You have to use colloquial terms like sugar ki bimari, right? So the context is so important of where you're working, right? And whether the things are possible. Lastly, about data representation, the thing that you talk about US, Europe data won't work in India. One thing we need to realize is even for women, all the data comes from men. There's a huge issue in medicine overall, that if you look at cardiac data, even pregnancy data, or any kind of data, it comes from male data. So you already understand how much the models are biased because you're starting off with biased data, right? And then what we find is that if you look at or context that we are working in, right? That when we work with scheduled caste, scheduled tribe women, migrant mothers, we work with Muslim women, or we work with adolescent mothers. Their data is actually not there at all because, and then technology, if not intentionally designed, can worsen access to these women. So we're really working very hard to get these women into the system, these children into the system, and then build models based upon the data that we collect. And then otherwise, it's all biased data, right? Yeah. So just very shortly. Yeah. Thank you.
I mean, and second, everything that Aparna has already said, I think I'll talk about three things that are additionally also very important in the context that we work in, and especially for health. One is, I think, similar to what Aparna was pointing out, and you were saying, we also chatbot is based on RAG. So we limit it to sort of protocols and guidelines given by the government on what ASHA workers can counsel people on. And that's really important because you could end up in a solution where the LLM chatbot is hallucinating, giving sort of wrong advice. So I think safety is a really important question. I think especially in health, it becomes much more important to think about how do you design for keeping that in mind, and potentially like sort of having more guardrails around that is something that's going to be useful in the future. The second thing that I would emphasize is, and this is the case with any digital solution, which is designing with the user in mind and how they are going to use this solution, and what are their constraints. So, we often talk about digital readiness as like, okay, do they have a smartphone or a feature phone? Do they have internet connectivity? But like one thing we've learned in rolling out the chatbot is that even the way that the ASHA is able to ask questions from the chatbot, the kind of prompts that they use, they will not be the same as what you and I might end up doing, right? So that's another element of literacy, and they need more guidance on how to ask the right questions to get the kind of response that the chatbot is capable of giving. The third thing I would say is, and this is something we're sort of looking at not just here, but in some of our other solutions, is designing for scale, right? Like right now we're working with, let's say, 11,000 ashas. Once this moves beyond it, how do we do the same things, and how do we sort of check for the same safety and update them? And as the model updates, how do you account for that, right? So I think that's something to also keep in mind.
Um, Okay, I think that really summarizes us, and that was a very loud timer. I know we started late, but just so that the rest of the sessions can continue on time, I will actually move towards wrapping us up. I just want to have a loud round of applause for our panelists, please. And I think some excellent, very insightful ideas here. First of which is the designing with the user. Urvashi, I'm so glad you said that. And then really making sure that the models do account for heterogeneity, that we are considering heterogeneity of context. I see the organizers move towards me, so I will wrap this up with gratitude for this panel. Thank you.